let's get started with traumatic brain injuries. So, anatomy, the brain, and then I also want you guys to be familiar with the meninges. So that's the 3 layers that surround the brain. You got your dura mater, which is on the very outside. Then you got the arachnoid mater, which is in the middle layer. And then you got the pia mater, which is the layer that's literally sitting right on top of the brain. So I want you guys to be aware of this because sometimes with the traumatic brain injuries, you're going to have bleeding into one of these subdural spaces, or like the subdural space would be below the dura mater, the subarachnoid space below the arachnoid mater. Pia mater, because it's right on the brain, it's just going to be pushing on it if there is any sort of pressure, because sometimes we can have a traumatic brain injury from like swelling and an increase in intracranial pressure. So let's kind of talk about this. So I hope everybody can see this whole screen here, but etiology of traumatic brain injuries. So I would say the number 1 reason here is a fall. So this is either they have a baby has been dropped or something like that, because remember, this can happen in our pediatric patients. A lot of times a fall is going to be consistent of either an accident or something like that, like a skiing accident, snowboarding accident, something like that, where like the person straight up falls over and is traumatically hit, aka traumatic brain injury. And then also I'd say the most common reason would be an elderly patient has fallen, and that is why they're having a traumatic brain injury. So the next common reason would be a motor vehicle accident. So this is where we'll see that coup contra coup injury. So that's where the brain hits the front and then hits the back, and then it'll hit the front again. So then you have damage to both either the front, to both the front and the back of the brain, or it could be a side injury. So it could be like a boxing accident too, and they like hit the side of their brain, then it hits the other side and goes back, or like football or something like that. All those kind of fall under the coup contra coup injury. So again, motor vehicle accidents, super common. MVAs are going to be a common cause of a lot of neuro things, such as spinal cord injuries, as well as TBIs. So the traumatic brain injury can either be an open injury. So this is like a gunshot wound literally penetrates through the brain and the skull, and that is how the person is ending up with a traumatic brain injury. I like to think an ice pick to the skull for some reason. That's how I remember what an open is. And then you could have a closed injury. So then again, that's a coup contra coup. A closed injury could also be like a hypoxic injury due to brain swelling or hemorrhage or something like that. Some sort of loss of oxygen to the brain would also be considered a closed injury. And then any sort of hematoma, such as blood formations, or any general increase in intracranial pressure. So you'll see this a lot with like little babies with their like little intracranial pressure monitors on them following any sort of like subarachnoid bleed or something like that due to a traumatic birth. So you'll see that monitor on them, which is like really sad and it's so hard to see. But you'll see this a lot in like just the ICU in general, either NICU or adult people ICU, with their intracranial pressure monitors following a motor vehicle accident. So this is important here, guys. The people at the highest risk for a traumatic brain injury are people in the following age groups. Age 0 to 4. So again, babies, due to like some traumatic thing happening with either the babies like rolling off the table or something like that, falling, little kids ending up getting hurt or something like that. Unfortunately, also shaken baby syndrome. That's a cause for a traumatic brain injury. That is, again, another coup contra coup injury. Teenagers aged 15 to 19, because their prefrontal cortex is not developed yet, and they're making a lot of dumb, irrational decisions, such as, you know, I can totally make that jump with my snowboard and everything. They can't do it, or they're doing something irrational with driving because they just got their license. Again, motor vehicle accidents. And then any geriatric individual over the age of 65 is more at a risk of a traumatic brain injury, and that main cause is going to be falls for those individuals. And in all of these categories across the board, men are more likely to have a traumatic brain injury than women. Same kind of thing with the spinal cord injuries. Men are more likely to have them than women. What does it look like? So a traumatic brain injury is going to look like a man, most likely, if we're looking at a board's question, that's the thing. And they're going to be any of the age categories that I previously mentioned. So that's 0 to 4, 15 to 19, and then 65 plus, most likely. So that's how it's going to show up on the boards. they're going to have altered levels of consciousness. Either they're anywhere from a coma or to varying levels of delirium. So they're very confused and agitated, and maybe they're just not acting quite right. So you'll see those behavioral changes and personality changes. All of a sudden, let's say it's like your best friend who's had a traumatic brain injury and they used to be like really outgoing and bubbly and everything. Now they're very like quiet and reserved, and they would never think of being the center of attention for something. That's kind of how it ends up being. Just their whole entire demeanor changes. Because a traumatic brain injury is an upper motor neuron lesion, it's going to present with the hypertonicity and the spasticity. So that you're going to see a change in tone in this patient, and it's probably going to lean more towards the spastic, hypertonic kind of edge of the spectrum. Now, sometimes you'll have a traumatic brain injury and they're completely flaccid, but usually it's presenting more the hyperreflexive, hypertonic, spastic kind of presentation. Again, this patient is going to have issues with speech and swallowing probably as well, due to the fact that they had a central nervous system infarct and problem, obviously injury. And a lot of those issues are going to be treated by a speech language pathologist. So this is where our interdisciplinary, like, fun things come in. And we love our SLPs. We love our speech people. They are awesome. I love my speech therapists that I work with. They're killing it. So we definitely want to be using them when it comes to a patient like this. This patient is also going to present with a lot of motor impairments and a lot of motor learning disorders. And what I mean by this is, like, they are unable to complete certain actions, kind of in the same way we see patients who have a CVA with apraxia and stuff like that. So you like tell them to do one thing, they can't do the whole sequence kind of thing, or like they can only learn previously learned tasks. Their muscle memory isn't quite there. That's kind of what I mean by a motor learning disorder. So let's kind of go over the two ways that we would classify a traumatic brain injury. So the first one is the Ranchos Los Amigos levels of cognitive functioning, and I've abbreviated it because it wasn't fitting in the title. So let's just go through this quickly. It is a scale from 1 to 8. 1 being they're in a coma, nothing's going on. 1 is called no response, all the way up to level 8, which is called purposeful appropriate, which is essentially the patient is as normal as they can possibly be, but there's someone that like really needs like structure and stuff like that to make sure that they're functioning within their like abilities. So let's go through this really quickly. 1 would be no response, the patient's in a coma. 2 is a generalized response. And this is when like you would squeeze their toe or something to create like a painful response, and then they'll like move their arm. So it's weird. Number 3 would be a localized response. So like if you squeeze their toe, then they move their foot away. They kind of retract their leg, kind of almost like a heel slide kind of thing. Number 4 is confused agitated. So this is the patients that have the short attention span, very quote unquote ADHD, like they're super combative because they're agitated, so they could end up being very dangerous. And that's why the boards really likes to hone in on level 4 in the Ranchos Los Amigos levels of cognitive functioning. If they're going to have a question on a specific stage, they're going to pick confused agitated like more often, just because this patient is such a safety risk. And we worry a lot that they're going to do something that is dangerous. So you want to make sure you're treating this patient in a nice, quiet room away from other people and without many distractions, because they can literally barely focus on a single task. But that's just kind of how it works. Number 5 is confused inappropriate. So this is a patient that cannot learn new information. So if you're trying to teach them how to, I don't know, something, do something that for the first time, like learn how to use a new game on their phone, they're not going to be able to do that, but they can perform previously known tasks fairly well. So this would be a patient that like if you're trying to teach them how to get dressed again, they can pick up on it pretty quickly because they remember, okay, I put my arm through this hole, then I put it over my head kind of thing, and it's good. Confused appropriate is stage 6. This is a patient that would need cueing to get through to their goals. So let's say the goal for this patient is we're going to fold a load of laundry. They would need cueing to take the laundry out of the dryer, put it in a basket, pick up the basket, bring it over to a table, set it down on the table, pick out the clothes and fold, to like re-explain how to fold them. But this patient knows how to get to the goal. The patient says, my goal is we're going to fold my laundry. but I need help getting there. That's kind of where this patient's at stage 6. And stage 6 is called confused appropriate. Stage 7 is called automatic appropriate. And this is a patient that moves very robot-like. So think just very automated movements. They're not really like, it looks like they're just like completely like in the zone kind of thing, just doing it. And it's very rigid kind of structure. And this is just because this is how the patient is able to get the task done. It has to be like super, super rigid in this specific certain manner. So that's why it seems like a robot. It seems like they're just following like a script or just instruction manual. There's not much wiggle room for spontaneity kind of thing. And then number 8 is the purposeful appropriate. And as I said before, this patient is essentially quote unquote as normal as possible if we want to like kind of break it down simply, but they need a lot of structure. So this is a patient that you would see with a lot of, as I said before, a lot of similar traits in the sense that they need to have certain things in a specific order, that they need their structure in their life, that they can't be overstimulated by certain things because that could send them into a spiral. So we would not want this patient to be overstimulated in any way, but this patient can still like, you know, go to work, do their job and stuff like that. But it would be a situation where like, if there was all of a sudden like a detour on the way to work and they had to change their whole day around, or like, let's say like a plan was canceled that they were planning on going to and they planned their whole day around it, that might kind of send this patient a little bit into a, like, I don't want to say a spiral, but it'll get them like off of their task kind of thing. So again, the patient will progress from stage 1 to stage 8, maybe. They might never ever get to stage 8. They might, the most that they could ever recover could be all the way to stage 6. So they just need queuing for their entire day to get things done. And this patient could progress all the way to number 8 and be fine. And the patient can skip around. Let's say one day they're a generalized response and all of a sudden they're in the confused agitated. Like it's not like a linear progression, but the boards likes to classify patients in this specific way. So Glasgow Coma scale is the other way that we would classify traumatic brain injury patients. And this is on a scale from 3 to 15. Now there's specific things in each section, like how much are they opening their eyes? Are they opening it to pain? Are they opening it at all? Their motor response, is it like they're moving like in a decerebrate positioning or something like that? Then verbal response, are they groaning? Are they making sentences? Are they coherent? There's a lot of different stuff with the Glasgow Coma scale. But this is what you need to be mostly focused on, because the boards is kind of, I'm going to say this, the boards is going to be an asshole if they ask you like, what score is it for a patient who like only opens their eyes to pain? Like that's rude. They're going to ask you it in this way. From a scale from 3, so 3 this is the lowest because you only get 1 point for each thing. So you'll get, actually, hold on, let me say this thing first. So the only things you really need to know is that the eye opening is ranked on a scale of 1 to 4. The motor response is on a scale of 1 to 6, and the verbal response is on a scale of 1 to 5. So if you add all that up, that's 15 points total if you have the max amount. On a scale, this is the stuff that you want to know, so pay attention to this part. If you score between 3 and 8, you are in a coma and you've had a severe brain injury. So 8 and below, you're in a coma. So 8's the magic number. If you're 8, it's not great. That's how I remembered it, because of that 8 or less was in a coma. 9 to 12 would be a moderate brain injury. And then 13 to 15 would be a mild brain injury, so such as a concussion. And I want to point out, a concussion is still a traumatic brain injury, so it should not be taken lightly. And if you are treating a patient who has a concussion, we need to make sure we're following the protocol appropriately, because we don't want any long-term effects. So it's not quote unquote just a little concussion. No, you've literally had a traumatic brain injury. So how are we treating this patient? So I went over all those levels, all those classifications, blah, blah, blah. That's because our treatment literally depends where are they at. Like, I'm not going to give a laundry task to a patient at stage 1. At stage 1, you're just doing like PROM and stuff like that. You're keeping their joints from getting frozen shoulder like everywhere, essentially. So we as PTAs and even as PTs, we're not making the diagnosis of what stage they're at. We have to be familiar with the stages for treatment, obviously, but the neurologist is the person who's making that call. So the biggest thing for us, because remember, the boards is a safety test. Not about how cool of a clinician you are. The boards is a safety test. So safety things. With the Ranchos Los Amigos levels of cognitive functioning, the stage 4, so the confused agitated state, is the one the boards loves to talk about. So we need to be careful with this patient because they can be dangerous and combative. So that could harm either us, the patient themselves, they could accidentally hurt themselves, or they can harm other staff members, or other patients. So we have to make sure that we're careful with this patient, that we're treating them in a nice quiet room away from other people, keeping them focused on very simple tasks if we can, and just working on what we can with them. So be careful with that patient and make sure we're treating appropriately for whatever level that this patient is at. We're not trying to overdo it with them, because any patient, if you're trying to make them do a task that they're not at the level that they could handle it, they're going to get agitated and upset, and there goes all your focus on your treatment. So the big thing is we want to watch for intracranial pressure on the intracranial pressure monitors, because if we see that going up at all with this patient, because we could be in a hospital doing PROM on a comatose patient, we need to make sure that we're keeping an eye on that, because we don't want that to be going up at all, because that could be problems. And we also have to know the signs and symptoms. So we see a patient's having an increase in intracranial pressure, which is going to look like they're going to have like a really terrible headache, and it's kind of going to look a little bit like a stroke sometimes. So be careful with that. The main things we're doing with these patients in general are working on functional mobility. So whether that be transfers, whether that be working on range of motion, all that stuff. Biggest thing, and I always preach this with everything, guys, when we have a patient that might not be able to take care of themselves, caregiver education. And when the patient reaches the stage where they're able to coherently understand and process what's being told to them, patient education as well. So making sure if it's a patient that's either comatose or in one of those like generalized response, that we're teaching how to do like range of motion and stuff like that to any caregivers. If for some reason they're in there with them, we're going to be in the hospital for most of that. But, caregiver education for just understanding that the patient is going to progress through certain stages. They might not get all the way to stage 8, and they're just going to do the best to help support the patient in whatever stage that they're in right now. Behavior modification. So this is kind of, cognitive behavioral therapy for these patients to make sure that they're not doing anything dangerous to hurt either themselves or other people, and that we're making sure, like based on where they're at right now, that we're kind of modifying things to help them out. We're going to work on wheelchair management. So that, again, transfers, this patient might be in a wheelchair because they might have a lot of those like motor learning disorders and stuff like that, and motor deficits that they're going to need a wheelchair for community ambulation. And we're going to teach compensatory strategies with this patient, similar to how we could teach that with spinal cord injuries, because if they're stuck like this for the rest of their life, we have to work on making them as functional as possible for wherever they're at. Kind of, we got the cards we're dealt, we got to work with it. And so, yeah, essentially making this patient as functional as possible. So keywords for this, anytime you see Ranchos Los Amigos levels of cognitive functioning levels, that's, traumatic brain injury. Start thinking about all this stuff. Level 4, as I said before, the confused, agitated. The boards, for some reason, they love this one. I'm assuming because it's a big safety thing to make sure the patient's not hurting you or other people. Again, another thing, do not let a patient block your exit. Do not let a patient block your exit. Any male patient between the ages of 0 and 4, 15 to 19, or 65 plus, because they're more at risk for a traumatic brain injury. Any patient who's had a fall or motor vehicle accident, start thinking either traumatic brain injury or like broken bone or, spinal cord injury, something like that. Glasgow Coma scale, again, same kind of thing as Ranchos Los Amigos levels of cognitive functioning scale. Any sort of like subarachnoid hemorrhage or increase in intracranial pressure, something like that, that would also indicate either any sort of stroke or traumatic brain injury, just increasing intracranial pressure. And then a contra coup injury, that is classic TBI. So if you see any of these keywords, start thinking that. Sample question: which one of the following individuals would be most at risk for a traumatic brain injury? 1, 30-year-old female. 2, 30-year-old male. 3, 70-year-old male. Or 4, 70-year-old female. So I'll give you guys a second to think about that. All right, guys, the answer is a 70-year-old male. And this is because if we look at our common age groups, The highest risks for TBIs are either that 0 to 4, 15 to 19, or over 65. And a male or a man is more likely to have a traumatic brain injury than a woman. So I hope that that helped explain the questions. So they're going to ask, a lot of the board's questions like to ask, which one of these individuals would be most likely to have this condition? Remember, we kind of talked about adhesive capsulitis and how that's a middle-aged woman between 40 and 60 who has diabetes, something like that. So they're going to give a list of things that you would be like, okay, like what kind of patient would be most likely to have this kind of condition? Because they want you guys to like be familiar with the risks for certain populations, for certain diseases. All right, guys. Well, that's all I have for today. So you take care and I'll see you in the next one. Bye, guys.